Hello, everyone. Thank you for joining us today. This is our fifth session in the series on the future of primary care in BC. And today we've got guests from Oregon to help us see into this future that we're proposing and see what a primary care system transformation looks like almost a decade on, I think. I'm Veronique Siufi. I'm the racial equity researcher and policy analyst here at BC Policy Solutions. We work on the unceded stolen territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. And for those of you that might be tuning in for the first time, not familiar with our work, BC Policy Solutions is a progressive public policy research institute. So we're looking for those, policy redesigns that are going to make life in this province better, as in, healthier, more sustainable, more affordable, ideally more just. So we've got economists calculating how we can better redistribute wealth and how investments in public and social infrastructure, are not only the right thing to do, but good for the economy. We've got social scientists like myself doing community-driven research. We're also a hub for cross-collaboration across community organizations, nonprofits, academics, the labor movement. And then we try and make all that work that we do accessible to all of you, like what you're tuning in for today. So for those of you that have been tuning in all along, you've seen that this series is focused on a particularly great example of how when we design our public systems with equity in mind, meaning, when we make sure our systems work for the most marginalized, they do end up working really great for everyone and saving us some money. And we're seeing that this really requires a clear values-based guidelines, some community responsiveness, of course, stable funding, and ideally that we stop treating our public services like market businesses. Now, we're really lucky to be joined today by Andrew Earnshaw, who will be facilitating the conversation with our great panelists from Oregon. Andrew Earnshaw is Executive Director at the Kootenay Boundary Division of Family Practice here in BC. And for the last 14 years, he's worked with rural physicians, nurse practitioners, health system partners, and community leaders to advance primary care reform, strengthening access and support more sustainable, team-based, and community-driven models of primary care. So as you can see, he's facilitating today's discussion because he clearly believes in fulfilling the promise of, comprehensive primary care, and that's the best way to meet shifting demographic demands while preserving that integrity of, Canada's public healthcare system. So I'll pass it over to you, Andrew, to get us going today.
Thanks so much, Vera, for that warm welcome. Welcome to all of you, and thank you so much for joining this. I was trying to think about what would I do in my little intro, and I was reading the subtext of this thing, improving healthcare while lowering costs. So what else could we wish for? And I guess the next hour or so, we're going to get into the devilish details of that simple little phrase. And we have some fantastic folks here from Oregon who can really speak to a great example of going from local expertise and good examples into full broader system change, and how that change was really supported on the ground. And that's really what we're here to learn about today. So I'm going to introduce our guests alphabetically, and then we'll just get down to it. So first of all, Dr. Liz Powers on the center of my screen. Liz is a practicing family physician, the local public health officer for Wallowa County, Oregon, and a health services officer at Winding Waters Community Health Center based in Enterprise, Oregon. She spearheaded Winding Waters' transformation from a private practice to what we in BC call a community health center. And during her tenure as the CEO, Dr. Powers led the organization to become Oregon's first ever 5-star patient-centered primary care home. So I'm looking forward to hearing more about that. And while Liz's local work is, of course, what we're going to be speaking about deeply today, and probably where she's going to start, she's also well known for leveraging this ground level implementation and expertise in multiple statewide settings. She's served as clinical transformation consultant for the Oregon Health Authority for over a decade, and she's been recognized by numerous accolades, including the HRSA COVID-19 Public Health Champion Award, and last but not least, Oregon Family Doctor of the Year. So welcome, Liz, and thank you so much for joining us. Dave Ross is the Director of Population Health for Comagine Health. He has over 18 years of experience providing a deep background in facilitating complex strategic initiatives focused on quality improvement and system transformation at both large and small scales. Dave's an expert in clinical implementation of practice change. He provides high-level technical assistance to diverse healthcare stakeholders, helping both organizations and full health systems adopt team-based care models and evidence-based practices to improve population health. And including, of course, his tremendous leadership in this space in Oregon's primary care transformation that we're here to learn about today. So welcome also, Dave. Last but not least, Dr. Evan Saulino. Evan is the clinical director for Comagine Health. Comagine is a national nonprofit healthcare consulting firm. They work collaboratively with patients, providers, payers, and other stakeholders to reimagine, redesign, and implement sustainable health improvements in the health system. But of course, Evan is here today because he was the clinical advisor for the state of Oregon's patient-centered primary care home program, uh, which I guess means that you gave those 5 stars to Liz sometime in the past, Evan. Well done, well done. And his work was critical to the growth and success of this program's impact on more than 650 clinics, serving 3 million individuals, which demonstrated improved quality and over $1.3 billion of savings. So if anyone else wants to know how we might find $1.3 billion of savings in British Columbia in the next decade, stay tuned for the rest of this webinar. So that was my stab at a very light touch of the very much better bios that are on the workshop page for this particular session. So I think that just popped in the chat recently. If anyone wants to learn a little more about our wonderful speakers, please go there and learn more. So I guess without further ado, let's get into it. We'll just start with Evan. Evan, what problem was Oregon trying to solve? Why did the state decide it needed a different approach to what might be described as the usual sort of incrementalist approach to primary care transformation?
Yeah. So first of all, thanks for having me, and thanks to BC Policy Solutions for putting this series on. I just want to start by recognizing really the as I've seen these 4 previous sessions, I've learned a lot about healthcare in BC, the problems, the potential, but also recognize that there's a lot of similarities when you get down to actually giving people care, the problems that exist, the common issues that the people struggle with. Health-related issues, social issues are all common. And so really appreciate the opportunity to collaborate around ideas that maybe we can share to, again, help BC really improve the care that folks get. At the same time, having the end result be that because people get better care, financial outcomes are better for those that pay for care, including the province in your situation. So our situation was not unlike what BC is facing right now in terms of its fiscal issues, its financial issues. In Oregon, back in the mid 2000s, we were really struggling with our state budget. We, in our healthcare system, one of the ways we deal with budget problems is if we don't have enough money, we just cut people off of coverage. So our Medicaid program, which is pretty similar to your financing, we had cut hundreds of thousands of people off of our Medicaid program, and saw the results of people who had well-controlled illnesses when they had access to care and coverage lose that access, and simple things like hypertension that was well controlled was, people lost their medications and then ended up in the ER with a stroke. And we saw those stories come to fruition. I was starting my practice at that time. And we had a financial crisis, and we recognized that we did not want to just keep cutting people off of insurance or cutting what people get, the benefits people get, or cutting payments as the only 3 strategies to deal with fiscal problems and making sure people have health care. And our governor at the time, who was an emergency room physician, Governor Kitzhaber, worked with legislators to really create a vision for what if we have what he called a 4th way, which is essentially making sure more people get care, but they get better care. And because they get better care, there's less money spent on expensive care that is sort of too late or when the horses aren't out of the barn, and we focus on prevention and primary care. as a foundation to prevent bad things, the result will be good. So that was an idea that formed into a piece of legislation in 2009 that formed what Oregon called a patient-centered primary care home model. So it was similar to the medical home model that you all have some places have implemented really internationally, and it was based in evidence. Barbara Starfield's a lot of Barbara Starfield's research, public health research from Johns Hopkins, who really showed the foundations of why a healthcare system works, and how important primary care is in terms of access, continuity, the comprehensiveness of care, and the coordination of care as people move through the healthcare system. So this piece of legislation set up a program and basically said, create a program that's built around these 4 pillars that will affect all of primary care, all of the clinics across Oregon, and essentially created a goal that said that 80% of all Oregonians would get their health care through those clinical places that would be transformed, and set sort of a 5-year timeline, really aggressive timeline to make that happen. Along with that structure was recognizing that people would need some sort of technical assistance or support to actually make transformation. There would need to be money or dollars paid. It was time limited dollars, but dollars paid to help invest in some of these changes. And then there would need to be a structure and an understanding, like what do we mean when we say better access, coordination, all of that. And so it set up a structure to create a committee that is brought together of a whole wide spectrum of multi organization folks, from clinical folks to patients to insurance companies in our situation, to pharmacy folks with mental health background, community-based organizations, a variety of folks together to have conversations about what we would expect of primary care to make it, quote, better. But we had to agree on those things. It was a consensus conversation. And we started with sort of 10 what we called must-pass measures, or things that everyone would have to do to have a sort of minimum base and define what good primary care is. But then it also created sort of a ladder of improvement, things that you could do and you could grow into being really much better at coordinating care, or being much better at providing access, or whatever it is, in ways that were really responding to your patient population needs. So that was sort of overall, essentially, it was trying to address a fiscal problem and what I would say would be a moral or healthcare system problem of how do we get more people care at a way that is cost effective, and really recognizes the fiscal issues that we face, pay for less emergent care that's already too late, and pay for more preventative primary care upstream.
Thanks, Evan. I'm hearing 2 really interesting parts in that we've got a really good vision of the end state of what optimal primary care looks like, but you've also got a really good model or articulation of the path to get there, the ingredients that need to be in place. So let me try to summarize it, see if I got it right for sake of the rest of our conversation. You've got policy, you've got clear standards that need to be achieved, practice supports to do it, and incentives to move the journey along. Did I miss anything in that, or could you elaborate on that a bit?
Yes, that was a good summary. The thing I would add is really engagement. So community engagement. I used to call it sort of an engagement policy. So we engaged the professional organizations of various types. We helped set up collaboratives, learning collaboratives, so folks could learn from each other. We set up a structure that was really unique in terms of our verification. So if people said they're doing these things, they had to be verified by the state. But alongside that was built in a technical assistance arm, incorporating essentially peers, other clinicians who were doing this work, to help offer help essentially and say, hey, if you want to do this stuff, we will work with you over a period of time and help you do that stuff if you're not doing it already. So essentially not just putting sort of a something out in the water and say swim to it, but teaching people to swim and helping those people who learn to swim teach the other people to swim so that the whole group of everybody can learn to do it well.
It sounds like a really elegant cycle of both accountability and supports flowing from it, yeah, throughout the system. It's great. Well, let's turn to what it looks like on the ground. Liz, can you describe what this looks like in a real rural community and what made it work for your hometown?
Sure. I'm going to start, if it's okay, with a little bit of a story. My dad is a primary care doc. He was a family physician in the Upper Peninsula. And I grew up eating cookies at the nurse's station, and I would sometimes cross-country ski with him into the hospital to do rounds when the roads were closed. True story. And I didn't always want to be a doctor. At first, I wanted to be a vet, but then I decided I liked animals too much and it was hard to see them sick, and I liked talking to people. So I went to medical school and got my degree. And it was always a little strange to me that my parents, who always have been super loving and encouraging, didn't push me and weren't sort of vocal in their push to join primary care and to sort of take up that mantle and do that good work. And then I graduated. When I got my diploma from Stanford, was stepping off the stage, my dad gave me this really big hug. And he said, "I'm so proud of you. And I never wanted you to have to work this hard." So that was a really interesting insight. I went through my family medicine specialty training and moved out to Enterprise, Oregon, which has a lot in common with the Upper Peninsula of Michigan. It's the same latitude and it's frontier. So zero stoplights, zero fast food, more cows than people. Population 2.2 per acre, 2.2 humans per acre, not cows. There are more cows. And I started practicing, and I found that knowing the right diagnosis and prescribing the right treatment didn't make people healthier. And that what my dad said was true. It's really hard to see suffering and not be able to influence it. So there was truth to that insight. Just around that time, we had an opportunity in Oregon to participate in a research study called the Safety Net Medical Home Initiative. And that was a national study looking at the medical home model. And we were one of two rural clinics who signed up for this study. And it gave this opportunity to reimagine what it would look like to provide excellent comprehensive primary care in a rural setting in a team-based way. And we took that on and leveraged the resources of that study to add a couple of positions to our team. And, my first foray into chronic care management was on an Excel spreadsheet. We didn't have an electronic health record, and I used to have charts that I would carry around in a milk crate. My arms were very strong when I first started. And then in 2009, the PCPCH program launched, and that really, gave us a path forward. It's kind of like having a good cookbook. You have lots of recipes to choose from. Some you have the ingredients for, some you don't. You kind of look at what you've got. And especially in a resource limited environment, we needed to know where were our grant funding dollars available so we could finance it, and where were the humans who had the skills to do sort of the next step in our journey for team-based care. And so we, over the years, little by little, have leveraged available resources to grow our team. We started with integrated mental health, initially with health coaches and then to counselors. And now we have 7 counselors and a psych prescriber. We then added dental, again, starting with what we had. We had a dental hygienist who was from the community and looking to join our team. And then we've expanded that. We now have 6 hygienists, 8 dental assistants, 3 dentists, and a dental surgeon. And then another sort of, I guess, the other pieces of expanding the team were less about sort of whole body care. So adding mental health, adding dental health is because the body is connected and you can't really separate the mouth from the rest of the body. But the sort of more meaningful and maybe less apparent team-based integration has come from looking at the bigger picture of health and the reason why me knowing the right diagnosis and prescribing the right medicine doesn't necessarily translate into improved outcomes. So we've added, for instance, a clinical pharmacy team, nurse care management team, and community health workers. We've engaged in things like medical legal partnership, and our teams work on food insecurity and housing and transportation, and transitional care management. And then most recently, we've added public health because there is sort of an inseparable synergy between public health and primary care. So I think that background is like our scope of work has really expanded from where I started when I went into practice 20 years ago. And now, very rarely do I walk into a room and find a problem that I can't solve, but it's never me doing it. It's the team. And building the team with the resources you have to meet the need that you see in your community. And that's been really empowering. It's also been kind of hard to figure out the financing of that because I will say payment reform hasn't ever matched care transformation. It's slower. And we did go, when I first joined my practice, I was one of three managing partners. So I owned the business. And we transitioned to being a rural health clinic. So I was still a business owner, but with a different reimbursement rate because of our resource scarcity. And then over time, recognizing that would never comprehensively meet the need of a community that is under-resourced and has a lot of inequities and uninsurance or underinsurance rates, we transitioned to a community health center. And that with grant funding has brought in some additional resources. I think the last piece that I just want to say is that boots on the ground, my reality has really changed as well over the last 20 years. So what I used to be able to do with a part-time nurse that I shared with another provider, now I do with three medical assistants, three health advocacy specialists that work on prior authorizations and imaging referrals and helping people to get equipment that they need, helping with medical records, and it really, the complexity of what we're asked to do from a regulatory standpoint is so much greater that the team now must require an infrastructure that it didn't before to meet that regulatory burden. And then maybe the last newest addition on my team is AI. And this feels really important for two reasons. I feel like this has been the biggest change in improving my quality of life. So I love what I do. The bubble has not yet burst. And by growing my team, I was able to tell my dad, hey, I get to do this amazing thing and have an impact. And I don't have that weight. I don't have to work that hard. But AI has really taken a lot of pressure off cognitive load within the visit. I can sort of disconnect from trying to remember everything and I can just focus on intentionally hearing the conversation. And it has really positively changed my doctor-patient interactions. And it's also really reduced pajama time.
Wow. Well, I have a new question that just popped in my mind. How far is the drive from Enterprise to Nelson, BC? And are you taking patients from distant from afar? What a fantastic clinic. Brilliant.
Yeah, thank you. It's a long ways. We do actually take patients from afar. In fact, I treat patients on the Oregon coast or other places. We do a lot of telehealth. Access is a barrier, and we seek to overcome it as part of the public health work. For instance, we do WIC and immunizations and reproductive health and all that, but we also do HIV treatment. And so I have a number of patients in Eastern Oregon who can't access HIV care and can come to us for rapid start.
Wow, fantastic. And many of the doctors and patients that we work with here also have similar stories about AI's use and what an incredible improvement it is to the patient-physician relationship and encounter. So anyway, thank you for sharing that. I'll give you one more question, Liz, which is, Evan spoke to what I'm now going to reframe as standards, supports, incentives, and community. So that the state led or the state offered. So can you just speak just really briefly to like, how was that influence of the state's plan an enabler for you to get through the story that you just described?
So I think we definitely benefited in many ways from the state support, and that includes technical assistance, IT help, peer connection at state events, at other things. It also it's a little bit hand in glove, them envisioning the thing, us doing the thing, and us being able to talk together to policymakers about what we need to sustain and support the thing. So I think it's a little bit learning as we go, and it really feels like less of a lift when there are lots of really smart minds thinking and evolving things together. I think, a lot of the breakthroughs in how we were able to do this team-based care have come from very informal side conversations, like me going on a walk with my friend Dan from Springfield, who's a doc out there, and sort of rethinking how we did MA support in our practices. And that gave us financial resources to be able to hire a CHW. So I'm not sure if that answers your question, but it's been a little bit of a grassroots learn as you go model. And the state's been really um, uh, they gave us the map.
Mm. Oh, that's a great answer, and thank you. And a lovely segue to Dave for my next question here. What kind of support structure is needed to help practices make meaningful change in busy real-world settings? And with hundreds of average clinics throughout the state, not just the first one to get the 5-star award, but, sort of writ large across a large geographic area.
It's a great question and a big question. And I guess the place I would start to answer it is like, before diving into some weeds, that leadership is so important. And one kind of interesting thing listening to Evan and to Liz talk is just like a vision. It was articulated by leadership that was driven by numerous economic issues, systems issues. But change is an interesting thing, and change isn't something that is unique to healthcare. In fact, when we talk about medical home as a model, this is something that has existed in healthcare a long time. It started actually in the pediatric field in the 60s, and Barbara Starfield later did articulate new kind of ways of applying medical home to primary care, but there was a proof of concept there, and so the vision was easier to sell. But I think the part of it is acknowledging that if we're going to do change and we're going to support change, that we need to have a vision and sell a vision and create an urgency. So I would also just note that, like, I don't know if for anyone who's an implementation guru or a system science person looking at the work of John Cotter and him articulating stages of the change cycle, right? That you need to create an urgency. People don't change things they don't think are broken, and that's understandable, and that's intuitive. So we need to make the case, and people need to believe it and want to act on the fact that something needs to change, and they need to feel those reasons, and those aren't always the same, right? There may be a fiscal or economic reason why at the state level the governor thinks it's important, but it has to be important to Liz and Enterprise and Dan in Springfield and whoever else in urban Portland too. And it's going to look very different in each of those places, like significantly different. Having done this work implementing medical home with many sites across the state, the work that we do is different and it looks incredibly different, whether depending on the community they exist in, the populations they serve, the providers that are at the table. And so what I'm getting at is that I think Oregon took an approach that said, if we're going to be successful, we need to meet uh, clinics, sites, providers where they are and understand them and help them through a process that will get them to where they want to go, not where we want them to go, but where they want to go. And then we'll try and make those things the same-ish over time, right? And so, from a practical point of view, what that meant was resources were put toward technical assistance. And the way we approached it in Oregon, I thought was really good. They established something called the primary care I'm uh, I'm forgetting the exact name at the institute, Patient Centered Primary Care Institute. Sorry, and the organization I work for now was the organization that facilitated this institute, and essentially took technical assistance providers that already existed across the state, working in healthcare services research, working in implementation support, and said, let's come together and talk about how we approach this as a group. So instead of like creating a whole new technical assistance arm at the state, they pulled together the Oregon Rural Practice-Based Research Network, the Oregon Pediatric Improvement Partnership, Healthcare Quality Corporation. These were organizations that existed, had relationships, had a niche already in the state as it related to implementation and change and quality improvement, and said, how can we work together so that we're each working with the populations and the communities that we know to do this work. And so we all came together as technical assistance providers and said, how can we standardize some of these things, or how can we articulate a similar message, and how can we have an approach that meets people where they are, but still has some scaffolding and has some structure. And so that's been really important. And having this be an approach that is evidence-based, having entities that do technical assistance and know the science behind it and have tools ready to go to do it makes that process a really thoughtful process. And we did a lot of like sharing tools. That was part of the role of the institutes. Like if a certain um, if a certain entity went in and worked on integrating behavioral health, for instance, at a clinic and had a great tool, part of the role of the institute that was created was to share that among all the technical assistance providers and say, here's this cool tool that we used, or here's this great readiness assessment, right? And so that's a big piece, is that we came together and said, let's have some shared structure, a shared venue to learn from each other, because good change, it never ends. And that's one thing I think we've learned, and we knew, I think, but has been confirmed over the last decade plus, is that change never ends. Quality improvement is an eternal activity. There's not some plateau we're trying to reach. It's a circle that we're on, and we'll always be on. And that's part of the model too, right? Is that we need to iterate, we need to learn, and we need to change over time. And so that's happened. So meeting practices where they are is important. And then taking and supporting methods that are iterative and small. Like clinics can't close their business for a whole day and implement something brand new. One, that doesn't really work. It's not possible, and it would create a lot of frustration. So we knew we needed to do this with it's articulated the model for improvement, PDSA cycles. Some people say PDC cycles, but like small tests of change. Let's do this and facilitate and coach this work in a way that takes off bite-sized pieces and says, let's try something, let's measure it, see how it works. If it works, let's spread it wider in the practice. So approaching things with that view, we're going to meet you where you are, and we're going to try and work on small tests of change to get to where we want to go. And of course, in ideal situations, that's community based, right, and not top down. There is a role, and I think we'll be talking about that later, for different pressures. As I noted, there are intrinsic and extrinsic motivations at a clinic level for change. And sometimes it's a policy thing that comes from the top down, or it's related to incentives or payment structures. Sometimes it's intrinsic, and it's like, I'm trying to avoid provider burnout. So we're going to implement team-based care as a way to have everyone enjoy their work more. Sometimes it's patient-driven. Ideally, there are a lot of patient-driven changes, right? Like, how does it feel to be a patient going through the system? And that's why we change. I think in Oregon, we too tried to articulate those things consistently throughout our transformation journey of like, what are the different pressures and motivators that we can use to move the work along, whether it's payment structures or again, highlighting internal motivators at clinics so that it feels internal, it feels community oriented, and doesn't feel like a top-down mandate, even if some of it is a policy. I mean, that is a way to get something to move sometimes, is implement a policy, attach some funding to it, and we have seen that kind of thing be influential.
Wow, that's great, Dave. I'm wondering if there's, like, in our province, we have a number of structures that sound like what you've just described, the organization that I work for, Practice Support Program, Quality BC. I'm just wondering if there's something about the way Oregon brought that group together that really moved Oregon from place A to place B across the whole state. Was there something unique about that collaboration, or the mandate it was given at the beginning, or something like that, that was about transforming the entire system as opposed to offering individual clinics improvement if they're interested? Like,
Yeah, so um, I think the state involvement is really important, right? Um, the state really made that possible, right? That Institute of Technical Systems Providers. At the same time, I think, again, having this medical home program get developed in concert with the CCO and managed care structure in Oregon changing at the same time, just set up an environment where those things could grow together. And so, a model for medical home was articulated at the same time a payment structure for managed care was articulated. And those things, there was a Venn diagram with a lot of overlap between those two things, which really drove change. And the thing I would note about that is that both the Institute and the work of the CCO and the work of the medical home certification program itself all had advisory committees and updating standards was a community-based activity, pulling together people from all communities and fields to come together to update the standards or to weigh in on what the metrics are going to be for the coordinated care organizations that would really incentivize change on specific outcome metrics, for instance, right? So those things all coming together was actually really important for this to be something that spread across the whole state and not just these separate programs that had their own individual objectives. It was part of a larger logic model, I guess you could say, leading to across state change.
Great. Thanks, Dave.
If I could just add real quick, there was really we tried when I was working with the state of Oregon, we really tried to find the gaps in the system, basically. To pediatrics was an initial one where the initial thoughts about standards and what clinics should do was very adult focused. And then we focused on pediatrics. We had a lot of feedback from rural clinics that were like, we can't do the same thing as clinics in the city. And we tried to design, again, like efforts to help specific, areas where we felt like we were missing. Some of those were, and we'll get into it, but some of it was our the peer structure that I mentioned, the peer clinicians built into the essentially an audit process, but sort of like alongside in parallel. And we specifically tried to recruit folks that were from different communities so that they could be speaking to their communities about how to make change rather than the state or some expert from the urban center coming in and telling them how they were going to make things better. So that that it was intentional to find the gaps and make that learning structures, the institute that Dave was talking about, as well as overall, to be able to change the whole system and again find the pockets where we weren't able to change immediately and then change those later. As we all know, there's the early adopters and then there's the middle people and then there's the stragglers, and you want to bring the stragglers as well.
Well, my next question was actually to ask Liz about that, because I understand you were in that peer process, and I'm quite intrigued to hear the word Evan use the word audit. So that's interesting. That's not how I think of peer mentorship. So Liz, tell us a bit about your role in that work and what that was like for you.
Yeah, so I mean, I think the state does I would say a verification rather than an audit. And I think one of the things that I love about the medical home program is it always felt like a partnership rather than a oversight. That's a really different feel. So we looked forward to our site visits. We've had a ton of them. And we learned something every time. And we were able to share something every time. And I think the role of the state team is to bring, expertise in the standards and the intent around the standards and to help with implementation and actuation. And I think the role of the peer is to bring some lived experience about what works and what doesn't and what's hard and what's not. I think that one of the pieces, like the secret sauce in Oregon, has really been in recognizing the unique differences of communities and regions. So specifically, one of the things that we talk about a lot is equity and the importance of equity and how that means something very different. So when we first started speaking of equity, I would say it was in a sort of a historical perspective of race, ethnicity, gender, and has been expanded to include geography and age. And so I'll specifically speak to my region, which though it has some racial and ethnic inequities, we are 99% Caucasian, English speaking only, and the vast inequities that we face are geographic access disparities and age disparities because we're one of the oldest counties in Oregon and we're aging quickly, right? So being able to focus our equity efforts on those known under-resourced and underserved populations has such a broader impact. So being able to recognize both the importance of moving equity work forward and the uniqueness of each community has been really helpful. And I think peers help to translate that, and they have that lived experience. It's harder for a practice to say, like, I can't do and this screening because so and so rancher won't take it. And I can talk a little bit about my experience working with our ranchers and how we've come to not only accept screenings, but recognize the importance of it and sort of be partners in that and sort of the steps that we took to get there. So I will also say that as a peer, when I work as a transformation consultant, I learn something every time. So in some ways, I hope I bring value to the interaction, but I also really learn from the practices that we're visiting, and that then I get to bring back to my practice, and it enhances what we do. So it really is this infinite, I learn from you, you learn from me cycle, which is really cool.
Great. Your story really speaks to that. We talked about standards as one of the pillars, but community standards, the ability to locally tailor what makes sense in this place. That's really quite powerful. I'm going to do actually a little bit of a slight digression from the story of all Oregon, and I just wanted to talk a little bit more about team-based care and behavioral health in Oregon, which is for those of us who had the pleasure of listening to the third webinar. We met one of your colleagues, neighbors, Don Creech, who really helped with integrating behavioral health into this transformation that's happened. And I know that I found that very impactful. I know that many others did as well. So I thought we might steal 5 minutes of this webinar just to allow Evan and Liz and you too, Dave, to just speak a little bit to how that advent of that theory of practice and team-based care, which Liz, I think you spoke to briefly about all the great people that are working with you, has been impactful in this transformation. So maybe I'll open it. I'll start with you, Evan, because
Sure. Yeah.
Yeah.
Great question. And there are definitely like numerous team roles that when you get them on your team and utilize them well, it sort of blows your mind in terms of what you can do. Behavioral health is certainly one of them. Community health workers is another. I'd say pharmacy. I mean, a number of those roles that Liz was talking about. But specifically to behavioral health, I mean, to me, that changed so much of what I can do in primary care and what I can manage, and how I feel I'm able to affect behavioral health more than write a prescription, which was always like definitely not enough, or give people a phone number to call someone that I knew they would never get to. So it really changed it from being like a pain point in practice, like, oh boy, people have these issues I can't solve, to something that I actually could, with my team, make a huge difference in by having somebody to literally hand off in the clinic, with a warm handoff, and meet that person and bring them in and make them feel comfortable. And they didn't have to go anywhere. They could just be in my clinic. That to me was one of the biggest successes, and probably behind some of the cost savings we'll talk about and benefits we'll talk about across the state, and really was adopted pretty widely across the state. When I go to other states in the U.S., go to California, other places, they're like, what are you talking about, integrated behavioral health? Like, I've heard about that, but how does that work? And in our state, I work in clinically in an organization that trains new family doctors and a residency. And basically, people that I am training will not take a job when they come out of residency, will not take a job that doesn't have integrated behavioral health. They're like, we won't even look at a job if it doesn't have integrated behavioral health. So he made a huge difference in my practice. But I'm curious, Liz, if you have to pick a favorite team member. You can make me happy, but
I don't think I can pick a favorite team member. I would say, one of the things um, about recognizing and meeting local need using local resources is that skills pop up in unexpected areas. And um, this is really less about like, here are all the things you must do, and oh, you need all these pieces to like make this thing. It's what are the building blocks that you have and how can you put it together? All right, let me give you a concrete study. So we did a research project with OHSU and OCHIN, our medical record, and it was called the Mind-Eye Study, and it was looking at perinatal and postnatal depression in pregnant moms. And it was about partnering with a counselor, a psychiatric prescriber, and a case manager, and a primary care provider to do screening, and support and treatment for these moms in this high risk time. And as we signed up for this study, we said, wow, this is really important. This is a time of need. There's great um, evidence that if we can impact this, not only are we helping the lives of the moms, but we're also helping the lives of the babies, right? So this was a really emotionally charged area. We're like, yes, we're all in. And then they're like, okay, sign up your nurse care manager. We're like, yeah, no, we don't have one of those. Here's our clinical pharmacist. And they looked like they thought we were crazy because we're like, here's our clinical pharmacist who's going to case manage our perinatal moms. And he blew it out of the park. So his skills in motivational interviewing, his ability to connect, means that we still utilize him in this role. And it has changed the way those research institutions look at their research proposals because it really might not be a nurse or a counselor who is the right person to meet that need. And having a trusted community resource is game changing. So I agree with Evan, the resources that we have in our office to be able to send a little HIPAA secure Tiger message. It's like a chat. Hey, warm handoff in room 5, get the knock on the door. Here is my teammate, Brittany, that I was telling you about. She's going to help you with this. It's seamless. I don't stop the conversation. We continue on. And I think that um, so much of our illness, both our physical and our mental illness and dental illness, in at least in my community, stems from social inequities and structural injustice. And having a warm handoff to a CHW may be as impactful in changing mental health outcomes. I will say, since we were able to institute our medical legal partnership and help with custody issues and prevent evictions, we have saved the system many millions of dollars, and that's just hard to show.
Mhm. Wow.
I think I would just add, and this is really just reinforcing to a large degree what's already been said, is that to me, the integration of behavioral health, integration of pharmacy, integration of dental, these concepts, and especially behavioral health, though, really relate to just a thoughtful, objective-based approach to addressing health outcomes. So we can say we want to treat diabetes, but if one of the factors making someone's control of their diabetes difficult is an underlying behavioral health issue, then no amount of prescribing or 10 to 15 minute encounters with their primary care is going to address that issue. They need something else, right? So let's get someone what they need. Let's get the right team to be able to provide them what they need. If you're screening for developmental delay in children and you identify a child with a developmental delay, the behavioral health provider may be able to determine this is a parenting issue or an attachment issue, not a development issue, and let's address that here in the clinic with folks that you know and trust, an environment you feel safe and comfortable in, not in some other place across town. So to me, like that's the intuitive piece, is like, let's meet the need. What's the need, and let's meet it. Let's make an objective to meet the need. And that's just makes sense. And I think that the largest difficulty has been in trying from a reimbursement point of view and a systems point of view to put two systems together that weren't together before. And how do we pay for that? How do we make sure documentation requirements are meeting the needs of both systems as we try and put them together? And that gets really difficult, and maybe where you all in BC have a different environment in that way, and more opportunity to make that part more streamlined, because I think that's where there's been a lot of difficulty.
Mm-hmm. Well, I mean, definitely, I don't know about more opportunity, but definitely lots, but equally challenging here at this end as well, for sure. It was Don was the one that spoke to us a few weeks back around every medical problem is a behavioral health problem, or almost all. That was our starting point. And I love the story of the pharmacist who, as a medical professional, can lean into that understanding, not of course denigrating the incredible skill set that behavioral health specialists have within their own profession. So anyway, that's great. Thank you. Well, we're getting close to the Q&A, which we should probably get to fairly quickly, is because we really love to hear what folks who are listening in have to say about what they've heard so far and what they would like to know. But we can't get to that without, showing respect to that tantalizing $1.3 billion number that we started this whole webinar with. So Evan, maybe you could just lean in a little bit for us with, what have these results been like in this journey you've been on in Oregon?
Yeah, yeah. Thanks for the question. And this was one part that I forgot to mention was in the original legislation that was smart. It is very often not done with policy, which was to include evaluation. Are we doing something right here? And if so, is it meeting the outcomes we think we want to see? So there was money, defined to pay for a series of evaluations done primarily by folks at Portland State University, so not within the state of Oregon, but a university who was contracted for this work. I think we'll get a link in the chat here, but I'll tell you about the financial aspects and care aspects, but overall, the uptake of this work was essentially successful at meeting that goal I told you about at the very beginning of 80% of Oregonians getting their care through a patient-centered primary care home. And so right now in Oregon, there's close to 650-ish primary care homes in the state, which is somewhere around 3/4-ish of all the primary care clinics in the state. And that number has stayed pretty steady over the last 5 years or so. So we had a lot of growth initially, and we've had folks mostly stay with the program and keep doing this work, which is great to see. The evaluation that was done by Portland State looked at essentially what would happen. They did what was called a difference in difference approach and sort of looked at populations that got their care within a patient-centered primary care home and populations that did not get their care in a patient-centered primary care home. And they looked over, the most recent evaluation looked over 8 years from 2011 to 2019. And it broke things down and sort of slice and diced things into different populations to look at effects across, is this the same effect in pediatrics as adults? Is this the same effect in rural as urban? Those sorts of things. And overall, punchline is, in those 8 years, this program was projected to have saved over $1.3 billion a year, somewhere on the order of more than $300 per person per year, decreased cost of care. So for each person that got their care, the cost was decreased. Primary care increased, the use of primary care increased by somewhere around 12%, 10%, 12% during that time, which is what we would want to see. And so there were additional dollars flowing into primary care. We saw a few kind of interesting things in the data. Specialty care actually increased somewhat. Mental health, specialty mental health care decreased significantly. Specialty mental health care, not integrated primary care behavioral health. So specialty mental health care decreased. And then really big spending areas, pharmacy, inpatient, hospitalization, emergency department use decreased significantly. So overall, costs dropped more than 6% during that time. And those effects were seen really across the population. So actually the per person effects were a little bit greater in terms of the pediatric population, whereas the overall cost effects, just because adults are much more expensive usually, the overall cost effects were more appropriate and more apparent in the adult population. The effects were a little stronger in rural areas than they were in urban areas. Again, you can theorize why that might be. including helping people attached to efforts to help them improve where they may have been isolated previously. So overall, for each dollar of increased primary care spending, the overall healthcare system got $12 back in return. So it was a 12-to-1 return on investment. So again, financially, it was a clear success. Like, I don't think you can point to too many efforts across healthcare where you can say you saved over $1 billion in 8 years. And again, got the types of care patterns you wanted to see. You got more primary care. You got less sort of folks in urgent, emergent, tertiary care centers getting care that is too late in many respects, and more of that upfront work. So that's overall, and the engagement has stayed really quite good. As Dave mentioned, I think, and Liz mentioned, we have struggled in terms of, because we have such a complex system of payers, getting all of the payers to actually pay for this care. That is not happening in our situation. You guys, again, have a different situation where you have essentially levers that the province can pull if they want to take advantage of these opportunities. But yeah, those were the finances and sort of overall care effects that we saw in those in that evaluation. And there's the link there to the evaluation, which was in 2019.
Evan, can you speak to what percentage of the clinics of the region, or maybe percentage of the patients in Oregon, are experiencing this kind of care versus the kind of care that Liz started with when she first moved to Enterprise, if you will, sort of the private physician solo practice? How much adoption has come in this journey?
Yeah. I mean, two ways I'll answer that. For the things that what are called must pass standards, things that must be done, some of those are really transformative, like having 24/7 access to some sort of advice, like being able to communicate with your hospital when people are discharged. Things like that were really fundamental and really fundamental changes from where we were before, where you would walk in a room and the patient would say, Doc, you knew I was in the hospital last week. And I would be like, no, I don't know that. What happened? Those sorts of things used to happen. And so those changes were really fundamental. So those must pass changes were significant. So 650 clinics across the state, 3/4 of the clinics are doing that work. The rest of the standards, which is sort of a ladder up to that 5-star level, highest level that Liz's clinic is doing, the clinics are doing a variation of things in there. So again, some are doing better at things like integrated behavioral health. Some are doing better at coordination of care, or having patients engaged in driving change in the clinic. So people pick areas where they feel like they can do the best, and then essentially, can build up to that level of what I would say is the most comprehensive medical home or primary care home, which is the type that Liz is describing there. So there is that, a variation across the state. A little hard for me to say, what that experience is, other than those really big must-pass measures, which again were significantly transformative in terms of how people communicate and get basic care and advice.
Mm-hmm. Oh, great. Well, I think I might end this success story with Dave, because you've been in a kind of a unique role of kind of being at the coalface of watching this change happen in so many different places. So I'm just wondering if there's any final observations that you'd like to make, or sort of key success factors in those 4 components that we've now discussed that you think would be good for us to end on before we turn it over to the Q&A.
Yeah, I mean, I think first and foremost is that systems thinking is foundational to these efforts. In other words, that old adage, and I don't have a good attribution for it, but like, the system's perfectly designed to deliver what it delivers, right? Like, so thinking of it that way, I think, investing in systems, processes, thoughtful approaches to things, including an evaluation, as Evan mentioned, is important. And because of that, I think, what we discussed earlier in terms of multiple Venn diagrams crossing at the same time related to how care is paid for in terms of the restructuring of MCO, managed care organizations and coordinated care organizations in Oregon, coinciding with the development of shared standards around what a medical home is and how we might measure those, both in terms of evaluation and in terms of verification, and then how we might support people in taking those standards and implementing them in their context, in their setting, in ways that are meaningful to them in their communities. That having all those things come together, the policy, this practice support, the standards, that really is the environment you need for change, and that within each of those things is a complex history and a complex set of systems that really need weedy work, like really detailed, weedy work. And superseding almost all of that is relationships and trust and all that kind of softer stuff that, if you're going to have a collaborative solution, you need to invest in. And so it's a long and often difficult process, but that those things are really what lead to success. And the success that we have seen, I think, is rooted in doing those things pretty well. And that remembering that, um, you know, uh, it's not about unanimous consent or a unanimous agreement on all the things that get done, right? Like it's about agreeing that we can live with the solution that we collaboratively decide upon. So just that recognizing while we're talking about all the great things that have come out of it, it's through a bunch of compromise, and that they're at every step of the way, whether it's defining standards or coming up with a system for payment for medical home tiers, or even the technical assistance design, that there have been people walking away from those organizations that are like, that's not how I would have done it, right? And that's part of solutioning. That's part of coming to agreement on how, as an administrative entity, as a state, right? That we would come to a solution together, even though we are, Portland, a major metropolitan area, and also enterprise in the far northeast corner of the state, and that we're going to have a shared approach, and we're going to try and do something that fits everyone, and moves us toward improved care for everybody. So for me, it's kind of thinking of those things, really approaching systems thoughtfully, really involving existing communities, communities being the literal definition in terms of geography, but also communities in terms of technical assistance providers, researchers, clinicians, so that we're really informed by the best. And I do want to make one quick note that I saw in the chat. Someone referenced the NUCA model. And when Oregon was exploring how we were going to do this work, there was a contingent of folks that went up and toured the South Central Foundation and learned about the NUCA model. And so, and Liz was there. So just one of those things where it's like the curiosity piece, right? Like being curious and going and learning and doing research like that. That's been really important too. Everything we did and continue to do, I think we hope is informed by curiosity and going out and trying to find solutions, which is why we're excited to be invited here today and have this conversation. So thanks.
Thanks, Dan. Liz, I feel like we should give you 30 seconds to make any final comments of anything on your mind, or should we hand the mic to Vera? What would you like? We'll make some space for that.
Yeah, thanks. I don't have anything super insightful except to say that I don't feel okay, we're the first five-star clinic and we're touted as being innovative. I don't feel like we've done anything new. I think what we've done is had a lot of time like listening and looking and ears open and visiting and just being really open to thinking about doing things differently, and then seeing what other people have tried and translating it in a unique way to what works in our space. So I think being continually excited by the spark of possibility, and looking with curious eyes, and then bringing those ideas back and translating it. It's not a plug and play. It's really different. What implementation of integrated clinical pharmacy looks like in your practice will be very different from what it looks like in my practice. And that'll be dependent on the patient population, the resources of the community, the skills of the pharmacist, but like, how do we leverage everybody's superpowers and how do we take the ideas and make them work? That's pretty cool.
Great, thank you. Vera.
All right, shall I kick off our Q&A? I'm gonna start the Q&A with one of my own questions, which is a question that comes up in these webinars often, which is about around the patient perspective. So you've all mentioned in passing that the patient perspective has been part of this process, and I'm loving this iterative, I mean, maybe because I'm a researcher, but I'm loving this iterative, peer learning, bringing research in to the process of this transformation. But I'm wondering if any of you would be able to tell me a little bit more about how, patients' perspectives or their families or their caregivers, how that's been incorporated into this transformation process.
Yeah, I'll just take a stab in terms of the structure of the program. And then, yeah, Liz, I want to hear from you in terms of your clinic specifically. But So in defining the standards originally, and each time that they've been redefined, there are patient advocates who are part of the process, part of that standards advisory committee, and they really have shaped um, how we think about this work and how we interpret this work. As an example, access is one of the key pillars of this work, right? And access means different things to different people. But the program has defined it in the words that were given to them by these patient advocates, which is access means healthcare team be there when we need you. That's what access means. That means a lot of different things. That means in-person appointments. That means the phone. That means, pharmacy, different things. But that's what it means to the people receiving care. And so each one of those pillars for the patient-centered primary care home is defined by that patient-centered language. And we've incorporated patient family advisory councils, essentially an organizational structure at the clinic level, where that's one of the standards that people can be doing to show that they are engaging patients and families in helping decide what is changed or what's improved or what needs to be improved in clinical organizations. Liz, what do you do in your clinic?
Yeah, so I mean, one of the things about having a clinic in a small town is that it's really easy to know that the care we provide is not bounded by walls, and that it's patients are really a part of everything we do. All of our staff and providers are patients at our clinic. We see our patients at the supermarket and at the baseball games. We like there really isn't a separation between patients and clinic function. And so the community and our patients are very invested in what that looks like. I as you can imagine, from 2006 to now, there's been a lot of change in how we provide care. So one of the things that, for instance, was really hard is we went from rounding twice a day at the hospital to rounding once a day at the hospital. And patients got really upset when we're not coming back to visit them at 8 p.m. in the evening, and instead we were going home to eat dinner with our families. But when we expanded hours in the clinic from 8 to 5 Monday through Friday to 7 a.m. to 7 p.m. Monday through Friday and 9 to 1 on Saturday, people would literally like stop on the crosswalk in front of my car and be like, "Thank you for being open today," right? Like, so like we got patient feedback often and in many venues. But it is true that having the standards language from the patients matters. So like when we think about access, it's really be there when I need you. And the whole sort of encompassing definition of that. And so we have patients on our board. We have a patient family advisory council. We have patient focus groups. We do patient surveys. We have patients who are on all of our committees. And we really seek intentionally to have that voice in every decision, from like the little nitty gritty of like rolling out another lab interface with LabCorp. So we have access to cheaper labs that can sort of do expanded tests, to big things like clinic hours and do we open a new clinic in Wallowa. It really matters to have that community input. And so we've kind of hard baked it into how we work. And you also just can't get away from it. You'll get stopped in the crosswalk. Integrated dental. Yeah, stopping in the crosswalk to show me their new teeth. Look, look. I'm like, hi, hi. They're like, no, no, my teeth. Right. So we get lots of patient feedback, and it's good.
I would just add, and I'll try and be very quick, but there are structural pieces. So, in terms of the restructuring of managed care and going toward coordinated care organizations in Oregon and how care is paid for, a community structure to that was intentional. They're called community care organizations for a reason. They include community advisory councils that are meant to be members, local people getting care from that, paid for by that entity, influencing their improvement plans and how they, strategically address care moving forward. State level policy boards and committees. So, there's a health equity committee, there's a primary care strategy committee, there's all kinds of committees, make sure the consumer voice is on there. And then from a technical assistance point of view or a standards point of view as well, that as Evan mentioned earlier, that consumer groups and people with lived experience welcomed as equal members on those committees to participate and make sure that their voice is heard. And from the standards point of view, Liz mentioned it a bit, but that you essentially get points for different things you do to meet the standards, right? And that in terms of patient experience, things like having a patient family advisory council, like doing an experience survey that meets certain parameters, those things mean points on your standards, right? So you're incentivized to do it to get a higher score. So just wanted to kind of sum up all the ways, but I think it's important that all those ways are represented, right? That the policy pieces, there should be the consumer voice on there, and then in the practice too, right?
That's great. Thank you. And I've got a couple questions around what makes up a team in team-based care. Now, this is particularly for folks who maybe, we kind of jumped over this because we are the fifth session in this, in this series, and it was one of the things we dealt with in our first session. But maybe we've jumped over that a little bit too quickly because it can be a lot of different things. So you've mentioned a lot of different kinds of members, pharmacists, dentists, behavioral, therapists. So what is there a hard line definition of what constitutes a team? I've got a question about, what if somebody has two different sets of skills, like they're a dentist and a nurse practitioner, if that happens? Or Liz, you mentioned that your pharmacist was able to help support pre and postnatal care. So, can you jump in and give us a little bit more color, I guess, to what a team is in these settings?
Sure. I think when you look at the standards, it really is about outcomes. So, do you do things that help um, get to accessible, accountable, comprehensive, continuous, coordinated, family-centered, equitable care, right? Like those are our six standards. And are you getting there? And it doesn't define like who are the people you need. It could be a two-person team. It could be a one-person team if they're doing all the things. I think what I would say is the team is made up of the people who are there doing the work to serve the needs of the patient. And community and patient needs are different. I think the other question that you asked is just around maybe sort of traditionally siloed things like payment. So like there's a mental health payment, and then there's a medical payment, and then there's a dental payment. And those silos, those funding streams are different. And like, how do you handle a practice that does all three? Or how do you handle a person who does multiple things? Like a naturopathic doctor who's also a licensed acupuncturist, and those have different funding streams. And I would say that the sophistication of the payment system, maybe Evan or Dave have a more optimistic view of this, has not kept pace with the sophistication of care transformation. And so really what we are seeking to do in our practice is leverage braided funding streams, including all those silos as we can access them, and including grant funding to support the teams that our communities need. But it's not a straightforward plug and play. It is I think when you have workflows in place to really facilitate seamless and really low friction team-based care, some of that shakes out. What do I mean by that? Patient shows up in dental complaining of tooth pain. The dentist is like, there is nothing in the mouth. They pull me into the dental chair with its fancy lean back features and say, hey, can you figure out what's going on? I look in the ear and there are these vesicular lesions, and they've got herpes infection, right? So then I get them added to my schedule. I prescribe them acyclovir and the patient gets treated. Or, same thing, they show up, they've got a really elevated blood pressure, we do a handoff for hypertension. Or I see somebody who's got ear pain, turns out they've got an infected molar. There's a lot of crossover between dental and medical. And so what we do is we get our workflows seamlessly in the background ready to do an integrated and real-time handoff so the patient gets the care we need. And that's also more satisfying for me. Instead of being like, there's nothing wrong with your ear. Go home and suffer. I can be like, hey, can you bring your ray gun in? Just take a picture. Oh, yeah, there's a big cavity. All right, let's get you in. Dr. Best is waiting. It's much more satisfying for me as a human. It's much more patient-centered. But I will say the payment systems still struggle a bit with that.
The only thing I would add, just in terms of the question itself being around team-based care, is that one, as I mentioned when talking about kind of a quality technical assistance, it's like meeting clinics where they are regardless of setting is important. And so a practice in downtown Portland is just going to have a different overall structure and approach than a practice in a frontier area. And so in recognition of that, the standards in terms of the medical home standards related to team-based care are really more around functions than around individual titles or job descriptions, right? So it's like, are patients assigned to a care team? Tell us how you do that. But are they assigned to a care team? If no one's assigned to a care team, you can't do population health management because you don't know who's attributed to who and how you're going to care for that population. So it's really more about defining things, having an approach that allows a provider, regardless of specialty or field, to work at the top of their license. Are you having nurses do all the things that a nurse can do, or are there areas for improvement you could do there? So the concept of shared responsibility across a team and assigning patients to a team is what's important. How each practice defines that in terms of specific roles is less, as long as it meets kind of those high level parameters.
Yeah, go ahead, Liz.
Super eloquent. Thank you. That was what I was trying to articulate, not nearly as clearly. Thank you, Dave. I think the only addition, and why did I raise my hand? Because I think one of the things that is a fallout of integrated team-based care that we don't talk about very much, but it's very real, is it absolutely expands the scope of the people working in the integrated team. So for instance, our dental teams screen for substance use disorder and depression, and they screen blood pressures at every visit. That is not something that a dental team did before they were part of an integrated clinic. I can do dental blocks for dental pain for a walk-in at 7 p.m. and hold them with bupivacaine over until 7 a.m. when the dental team gets in and can extract a tooth. So like the part of who's on the team matters, but also the synergy between the teams means that our scopes, our knowledge, our competence, my ability to prescribe for severe persistent mental illness, like all of that changes because of our integrated team.
I've got a few questions around how payment works and how it might be different in Oregon and BC. And so I will come back to you on this, Andrew, but maybe I'll just start with the question about, how are the internal logistics of incorporating that warm handoff when you're simultaneously handling back-to-back appointments? And this might have to also do with payment models, which is why I'm kind of bridging this gap because it's, a bit about what gets incentivized in how you're taking care of patients. But maybe, Liz, you could start with, how is it that you're able to do these handoffs when you might have, I don't know, other patients in the waiting room? What does that look like for you?
Sure. I think so. I see an average of 30 patients in a day. So that's kind of a standard between 25 and 30, which means I have a lot of 15-minute office visits. I have some longer visits. I do full scope cradle to grave, including delivering babies, C-sections, scopes, vasectomies, colposcopies. So that all is sprinkled in. Just to give the other clinicians on this call a little bit of context. That said, I will say the warm handoffs have absolutely streamlined my day, made me much more timely. I'm way less likely to miss lunch, and I get my documentation and my orders done more efficiently. Why? Because I'm many times when I'm doing a warm handoff, I'm not the right one to answer a question about accessing a cane or a walker, or how, can I get set up for my sleep study? Instead, I could do a warm handoff to a CHW to get them the equipment they need, or a warm handoff to a respiratory therapist. Or if they really are emotionally upset, they've just had this really horrible thing happen and they need somebody to process with, I can do a warm handoff and step out of that room and know the patient's need is being met by somebody more qualified than me to do that thing. And I can walk on to the next thing in my day. And physically, the way that works in my clinic is I reach out to a team of people or an individual and I say, I need you, warm handoff, room 5. And they knock on the door. I am still in conversation with the patient. I haven't stopped the conversation. I haven't said, hold on, let me step out a minute and see if I find somebody. I send a message. I continue the conversation. When the knock happens, I do an introduction and then I pass off the care. So it actually improves patient outcomes and satisfaction, significantly decreases like doctor stress, because I don't have to feel like I'm holding somebody up for the next visit, but also like not addressing this really urgent thing. And it has really helped to make sure that that connection happens. It's way different than saying, hey, schedule with so-and-so on the way out, which in my experience is about a 2 out of 10 hit rate.
And can I just ask, Liz, so you see 25 or 30 patients, whatever, but if you did not have the team around you, there's no way you could provide that level of access. You wouldn't be able to see 30 people and unless you stayed up, right? Am I right? The team allows you to expand your access and do more things, or do you disagree?
I
Am I
mean,
going
I
too
could
far?
do the same cognitive job and be like, you have this and here's what you need and walk out the door. But my confidence of the patient actually getting better would be drastically lower. Or if I really wanted to do the comprehensive excellent care, and I hear you, Evan, like I actually don't, you can't go back. You can't see what excellence looks like and then go back to like not doing that. So I think if I were the one doing all of this, number one, I would be super stressed out because it's not my wheelhouse and it's not the thing that fires my passion. But number two, I could probably see about 3 people in a half day, like literally.
All right, well, we're coming near the end of our time here, and I do want to give you some time, Andrew, to, wrap this conversation up a little bit, but I'll point some questions in your direction that you can think about as you do your closing remarks, which is folks are wondering, how do we get this process going in BC? What do we need to apply, and how can we do it, particularly, when we've got a different payment context, right? We've got public healthcare here that operates slightly differently from Oregon. So is everything transferable? How are we doing this? So I'll leave you with the absolute biggest question right at the end and ask you to wrap up this whole conversation. All in 5 minutes or less would be great, Andrew.
What's funny, I was trying to think about how to ask Evan the right question around the policy piece of this, but then I thought, maybe what I'll do is I'll just try to summarize my understanding as a foreigner layperson and have the three of you, nod or disagree. So of what went on in the policy space, because I think the question you're asking, Vero, is about policy. What do we choose at a governance level to design a system by? So my basic understanding of the Oregon policy history is we decided to save some money by cutting back on primary care. Oops, that was a mistake. So the state legislature says, we end up spending more money. Let's change our mind. What we'll do now is we'll say, look, if you want to care for someone that we pay for, which in the state of Oregon is teachers, civil servants, most of the senior citizens, anyone receiving some sort of assistance, not the whole population, but a pretty big chunk. If you want to care for those people, there's some new standards you have to meet to deliver care to those people. The baseline is this. You don't want to meet those baseline standards, you're welcome to care for people who work for private businesses and we're not paying for them. That's the starting point. And then in addition, they say, what are they doing up in Alaska and everywhere else in a high-performing system? If you're willing to meet additional standards of enhanced level of care, we will pay you more to do that. So thus far, everyone's nodding. So that's the answer to the question, Vero. It's like policymakers decide that we'll introduce a system like this where our compensation, the incentives to care will shift based on the standards you meet. But it's not a simple story. It's also, and in addition, We'll provide you community members to help you really define what those standards mean at the local level. We'll allow you to customize that to how that's done in your context that makes sense for you. And we'll deliver this remarkable support ecosystem, not only with incredibly bright minds like Dave around how you actually change things in a busy medical practice, but fantastic peer mentors like Liz and Evan who will come along and be part of that wisdom. So to me, I think that's the answer to your question. I could pause and see, Evan, Dave, Liz, did I miss anything in that? And then I could wrap up.
I think that was a good summary. Yes, to one of the questions directly, like our fatal flaw is that we have too many payers, and getting those cats to actually support this work has been difficult. Our state government has been really supportive, and so you all in your space have the ability, the opportunity to learn from the operational structures and like how we set things up and align your financial structures to support the outcomes that you say you want, which is really the key.
Mhm.
And I would just note, when you think of systems, think of leverage, think of levers. And unfortunately, you have to. There is a business element to it, and that's unfortunate, but it's real. And so when you think about things like how our practice is compensated for PCPC or primary care home medical home standards, the contract that our payers, our managed care payers have with the state of Oregon to provide Medicaid care require them to have tiered payment structures for certification as a medical home. Now, the difference between here and where you are is that because we have 16, 17, I forget the exact number at this point, CCOs across the state as payers for this care, they each, because of their negotiations in the contracting part, can do that differently. So there isn't yet, to answer Justin's question, a balance of how a medical home is paid by different CCOs. It's different depending on the CCO that you work with as a practice, who's paying for your care. In a single payer environment, that could be the same, I'm assuming. So that's one area where I think there's opportunity, but just thinking of the leverage, right? It's the contract between the CCOs and the state where those negotiations occur. And then the flow down of that is that we have this a bit of a difference between how CCOs handle that tiered payment structure for medical home. But in essence, yeah, what you said is right.
And I guess that's your difference that you live with. But the part of the story, the way I tried to tell it is you have one CCO, it's the state of Oregon, who pays for an enormous amount of people's care. So they can set a standard and example and do research that says we saved 1.3 billion in this period of time. Hey, private payers, might you want to do the same thing? And that's what you're in the scaling stage you're at now. But that's probably the topic for a whole other hour and a half webinar. But
I will just add, in that evaluation, they did look across payer types, and the savings was across all the different payer types, not
right.
only folks that were paying for it. Was again shows that if you change practice on the ground, you don't change it for certain people. You change practice overall for the people that you take care of.
Yeah.
And finding that payment to make sure you can support the team that Liz was talking about is really a critical piece. You're not just supporting the physician or the practice, you're supporting that team that provides the care, again, that you say you want.
Mm-hmm. Hmm. Yeah, and as I think to Vero's introduction to me at the beginning, we have this challenge for access and supply right now, but we have just scratched the surface of the challenge of our aging population that's about to hit the rest of the healthcare system. And so just imagine what that evaluative report is going to look like and what kind of financial metrics will be coming from that if we can implement these kinds of robust teams in primary care, in the next decade or so moving ahead. I mean, it just seems so fundamental to me in terms of where we have to go. So anyway, Vero, should I try to, I've got 1 minute to go, eh? I'm just so delighted and honored and appreciative of the three of you for coming and speak to us. And really to the folks that we've had come and speak for all of this 5-part webinar series. I'll remind everyone to go to the BC Policy Solutions webpage and look at the fantastic session we did on nonprofits, on evaluation in Ontario, which really mirrors the sophistication that you guys have delivered in Oregon. It's quite fantastic. Mental health and substance use focus and the tremendous potential for nursing scope of practice in care. And now you guys have so generously brought it all together for us with this comprehensive story of how an entire jurisdiction can take those kinds of elements of excellence and land it, and how it is the comprehensiveness that's fundamental. The individual pieces are not good enough. You have to have that. What did you call it, Dave? I think you called it a wesh or a weaving or an interweaving or something. I put my fingers together when you were speaking to that and how fundamental that is. So thank you again. Farewell, last words to you.
Yeah, well, thank you. A huge thank you to you, Andrew, for leading such a fantastic discussion today, and of course to our panelists from Oregon. And a huge thank you to everyone for tuning in. I know some of you have been tuning in for all 5 of these sessions, and I know I keep saying it's a 5-part series, which would make today our grand finale. But I think we will be adding more. These have been quite engaging and popular, and I'd like to have a look at how housing support services can be integrated with primary care. So. Tune in for that. You know, you've probably noticed a major thread running through this entire series has been the importance of addressing the social determinants of health, you know, the everyday conditions of where we live and work and how those impact our well-being long before we ever need to step foot in a clinic. So, you know, if those are topics that interest you, then we do cover a lot of that ground here at BC Policy Solutions. So, you know, follow our newsletter and tune into other events and hear from other really great experts just like the ones we've had today. So thank you again, everyone, for being here, and we hope to see you at the next one.